Super. Well, it's 4:30, ladies and gentlemen, and I'd like to welcome board colleagues, invited guests, and everyone watching on YouTube to the Worcestershire Acute Hospital's NHS Trust Annual General Meeting for 2023. This has been a day of firsts for me in some respects. A first board development session for me as chair of the trust, and my first board meeting in public as chair of the Worcestershire Acute Hospitals, and now my first AGM. However, I'm a little bit long in the tooth. I think this is the 14th board that I've actually chaired, so hopefully I won't mess up this one. We are also delighted, though, that Worcestershire Acute has joined the foundation group and joins its sister companies of Wye Valley Trust, South Warwickshire NHS Foundation Trust, and George Eliot Hospital as part of the foundation group. The annual report is of necessity a historic document. It reflects the period under the leadership of my predecessors as chairs, Anita Day and Sir David Nicholson, and Glenn's predecessor as Chief Executive, Matthew Hopkin. I'd like to thank Anita, Sir David and Matthew for their hard work and dedication. I'd also like to thank the rest of the board, staff across our hospitals and our system partners for their enthusiasm, dedication and commitment during what was clearly an extremely challenging year. Certainly when I have observed staff and spoken to them in these first weeks of my tenure, I've been incredibly impressed by their commitment and desire to make Worcester Acute Hospitals the best it can possibly be. Worcester Acute, however, despite everyone's considerable efforts, we are not yet achieving the consistently high level of patients' experience and health outcomes that we want to achieve and our citizens want us to achieve. So we are very much on a journey. Worcester Acute joining the foundation group represents a new chapter for the trust. We're working with colleagues across the 4 trusts. We believe we can share best practice and support one another to improve patients' experience. And even in these early weeks, we're starting to see some fruits from our labours. I believe that Glenn and I, supported by board colleagues, can build on what everyone connected to this trust, past and present, has achieved to date. Together we will strive to enable our teams across our trusts to deliver even better, safer and more compassionate care for our patients, drive improvements not just in our hospitals but across our local healthcare system, and make a valuable contribution to the success of all parts of the foundation groups. So with that introduction, I just want to note some apologies. First of all, from executive colleagues Tina Ricketts and Christina Blanchard, and welcome colleagues Liz and Jules who are standing in for them, as well as 2 apologies from non-executive directors, Tony and Susan. Any declarations of interest? Please raise a digital hand if you have any declarations of interest which haven't previously been declared. So the last set of minutes of the meeting held on the 27th of September. I turn to my board colleagues who were there. Are there any amendments to those minutes that you would like to make? Please raise a digital hand. Okay, so if you're not happy to approve them, could you please raise a digital hand? So those minutes are duly approved. So with that and no further ado, I'd like to hand over to our new Chief Executive, Glenn Burley. We will then look at the review of 2022-23. Glenn will then hand over to Sarah Shingler for the quality accounts, and Sarah will then hand over to Neil Cook for the annual accounts of 22-23. And then we will have a presentation on the Look Forward Award from Glenn, and then I will take any public questions at the end. So Glenn, over to you.
Thank you, Chairman. And good afternoon, everyone. I'm going to fly the slides throughout this, so I'll be looking to my exec colleagues to say next slide, please, as we move forward. But I'm going to start. And as Russell said, firstly, I'd start by paying credit to Matthew Hopkins for being the chief exec through the period I'm reporting on. So I'm reporting on something that was nothing to do with me. So I don't want to take the credit for others. So thank you also for Matthew for the way he handed over the organisation to me when I started in August. Also, thanks to all the execs, past and present, who contributed to last year's performance, as indeed our non-execs that Russell's already mentioned. So I'm going to just talk through a little bit of the review of last year. So there's a lot of numbers on this slide, and I'm not going to read them all out to you, although the biggest one you'll notice is our laundry, over £1 million worth of million pieces of laundry laundered over the entire year. Also a huge amount of activity through diagnostics, through A&E activity, outpatient activity. And this really does demonstrate the number of individual interventions and activity that takes place across the entire organisation, from 4,875 births through to the really huge number of outpatient attendances that go on across our three main sites. So I'll move on. Lots of developments over the last year. So there's one or two that are pulled out here. There's far more detail in the full annual report that's available on our website. But firstly, the Community Diagnostic Centre at Kidderminster, which opened, and you can see there a picture of the ultrasound room. Also, new CT scanner there, and 3 endoscopy rooms as part of that development. Community diagnostic centres are being opened up across the NHS to ensure that we firstly increase capacity for diagnostics, but also to make sure that they're as accessible to our communities. So doing that in Kidderminster has been a really important development for us, and complements the capacity that we have across all of our sites. We've also continued in the major redesign of our urgent and emergency care services. And what happened in December was the acute medical unit opened and the same day emergency care unit opened. And throughout, we've also been doing the rebuild of our main A&E department, which will sit in the same building as those two functions. And that will be open next month. We spent a bit of time at this morning's board meeting looking at the components of that. I'll come back to some of the improvements that we'll be making alongside that later. It's also been a year where the NHS has been focused on its recruitment and retention of staff and supporting staff well-being. So you can see within the report that we talk about the staff support for people with undergoing fertility treatment, employer with heart accreditation given to us there, but also special recognition for the Worcestershire Works Well partnership, with some of the support that we're doing to our wider workforce. Also an important year in terms of our relationship with our main regulator, the Care Quality Commission. And we now at this stage do not have any services that are rated inadequate, which has obviously been a feature of previous years. So we're really pleased to see that. That main change followed an inspection in November of our urgent emergency care department, a report that was published in April of this year. We've also developed robotics. So at the Alex, which is our main site for elective activity, we've introduced robotic surgery for urology, and that will not only improve the outcomes for our patients, it's also been a great opportunity to train and develop and recruit surgeons into this new field of intervention. Also with digital innovation, and one of the quiet things that has gone on in the background of all the activity across the organisation has been the development of our electronic patient record. So we introduced a new EPR. Usually at board meetings, annual general meetings, people will talk about new electronic patient records in a negative way, but we're pleased to say that happened very seamlessly for the organisation, and now 27,000 separate records are created daily on our EPR, and there's further developments to come, which I'll talk about a little bit later. And then also our improvement system, the forward improvement system, we've been going through further rollout of that across the organisation, training staff in those improvement methodologies and focusing that work on some of our priority areas, including improving flow throughout our urgent emergency care department. I'm going to talk a little bit now about some of the constitutional standards that the NHS is here to deliver. And before I talk about the individual results on this, I would start by explaining that the constitutional standards have not been met across the NHS. More recently, COVID has played a significant part in that, but prior to that, the NHS was very challenged, particularly in areas where we were trying to manage increasing levels of urgent care and elective demand. So what you see here is an indication of what the target is in that first column, then the year-end performance in that middle column, and then a comparison back to the 21-22 performance. And what you can see there for a number of areas is an improvement, but you can also see some increases in demand for our services. One of the ones that I would point to in terms of a lessening of our performance is the 4-hour emergency access standard. Obviously, during the prior year, there was a lot of demand that actually didn't occur in the NHS. A lot of people didn't come to the NHS for all sorts of treatments, much of which actually led to an increase in surge in demand during this last financial year. But I'm pleased to see there have been some improvements, particularly on 2-week wait performance there at the top of the list. And we intend to make further improvements over the coming year. Looking at our people and culture indicators, the appraisal completion has improved during the course of the year. Our aim is that all of our staff will have an effective appraisal during the course of the year, so we move from 76% to 81%. Our sickness absence across the NHS, that's continued to be high. Obviously, what we've been experiencing has been continuing waves of COVID and a very high level of flu during last year. And obviously, we do try to ensure that we don't bring any COVID or flu into our clinical setting. So we've been quite rigorous in making sure that staff who are showing signs and symptoms are not at work. But again, we would like to see these levels fall because the NHS needs all of its workforce to be ever present. Our mandatory training compliance is relatively at the same level as the previous year, and our turnover rate has slightly improved. I'm now going to pass on to Sarah to take us through some of the key highlights of quality.
Thanks, Glenn. Hi, everybody. Next slide, please, Glenn. So our quality journey over the last 12 months, and really, as Glenn advised, it's a thank you to the chief nurses who were in post over that 12-month period. I'm representing their work and the work of the teams. So we published our quality account for 22-23, accounting on the previous year and also setting the quality priorities for 23-24. We've done that in the format of a quality house, which is held up by 4 pillars, and they're the 4 pillars of quality, which is to provide safe, clinically effective and positive experiences for our patients, relatives and carers. Last year, the team worked hard to strengthen the internal quality assurance visit programme, which exists within the Trust. And they welcomed the patient and public forum, valued members of the team back on site following COVID. They also expanded the terms of reference of the quality review visits to include our allied health professionals and our medical colleagues, and also have representation from the ICB's patient safety team. Also moving forwards, what we're looking to do is to work across our local system where we have peer reviews from both the local authority and the Community Health and Care Trust, so that we do really get some objectivity into our services when we review them. We've strengthened governance processes around audit and review and actually closing the loop. And now more work needs to go into how we are sharing those findings with our staff on the shop floor. We've introduced an additional programme of themed focus audits, which is supported by our our patient participation forum colleagues, and who have supported us a lot around the front door, around our patients who unfortunately spend long hours on corridors waiting for a bed to become available, and where we have had to board patients in non-designated bed spaces in ward areas. And the Patient and Public Forum have been instrumental in providing assurance back to the board around how those patients are being cared for, and that's something that we now want to expand on further. Next slide, please. So Glenn's already touched on the Care Quality Commission visits the 21st to the 23rd of November, and that was part of the system-wide UEC inspection. Within the UEC footprint, they also inspected the specialty medicine wards, the discharge lounges, Laurel 2 and 3, and also our endoscopy services. And both of our EDs have now been upgraded to requires improvement. As always with the CQC, there are recommendations, there were some must and should do's, and the teams are being supported to implement the required changes in order to improve further. But the teams are so very, very happy with the results of the CQC and extremely proud of themselves in that regard. Next slide, Glenn. So our priorities moving forward for the next 12 months. Since coming into post, we've established a nursing midwifery and AHP board. And this has oversight of several work streams to support the direction of quality improvement within the trust. It basically pulls everything together into one reporting framework. We're developing a roadmap to improve quality, which details the milestones and will include an outcome framework. We're reviewing and relaunching our Path to Platinum accreditation scheme, and we're aligning that to our partners across the foundation group. We're creating a Fundamentals of Care committee, which will be the operational workhorse group overseeing our improvement quality priorities. And we're also reviewing and putting in place quality boards in our patient-facing areas, so that we are very visible and clear about how we're doing, both the good and where we need to make improvements. And we're also introducing monthly inpatient experience surveys, which will cover all adult and children ward areas. And the purpose for that is to provide real-time feedback where we can link in with carers and wider family members, but actually take action there and then, as opposed to, months later via the inpatient survey, the national survey. And we're also really keen to develop a patient voice and involvement strategy with our partners. And at the moment, I'm just reaching out to people who can support us with that. And we're really pleased to be running our 4th annual Big Quality Conversation this year, which is the online survey, and that is taking place at the moment. Next slide, Glenn. So our quality and safety summary for the year. So VTE assessment, pleased to say that we achieved our target at 96.3%, and our trust attributable infections, so MRSA, we achieved that target. However, C. difficile infections remains a concern and something that we are targeting our focus on with the support of NHS England. Friends and family response, A&E and our acute services I've met and exceeded their targets. Maternity remains a challenge for various reasons. One of the main points here is how many times we contact our women at the point of their journey through maternity. We are looking to reduce the amount of times that we ask for feedback, with a view to actually hopefully increasing the feedback that is given. And mortality, our HSMR, our year-end position was 98.98, and our shimmy was as expected. And mixed sex breaches remained a challenge because of the operational pressures that we see at the front door, and looking to accommodate patients in ward areas in specialties in order to relieve the pressures of an overcrowded ED. But there is, again, focus work going on in that area. And I think I'm handing over to Neil.
Sorry, just before you do, Sarah, can we resolve that the quality accounts be received? So in terms of the director of the board, if you're not happy to receive the quality accounts, please raise a digital hand. Okay, so those will duly be received and noted. Thank you. So Neil, over to you.
Thank you, Chair. So Neil Cook, Chief Finance Officer. I took up post partway through the year in August 2022. So I'd just like to put on record my thanks to Robert Toole, the outgoing Chief Finance Officer, for the first 4 months of the year and the part that he played in our financial performance for 22-23. So next slide, please, Glenn. So yes, financial performance for 22-23. So continue to present challenges on the back of recovery from the pandemic. However, despite that backdrop, pleased to report that we did achieve our plan. Our plan signed off by NHS England was a £19.9 million deficit, an overspend, and we came in at 19.8 million overspend, so a slight improvement on the plan that we had submitted to NHS England and agreed with the board. As part of that, we did make some significant savings. We saved £10 million as part of our productivity and efficiency plan, of which 8.4 are recurring, so we'll make those savings on an annual basis. However, it wasn't plain sailing as a financial year. There were some challenges in terms of increased clinical capacity that we needed to put in place, increased staffing costs. And as a consequence, we needed to use some non-recurrent funds in order to achieve our financial plan, some of which was generated through slippage on business cases, natural slippage, and some of which was generated from one-off benefits taken from the balance sheet. So the pie charts that you see on your screen in front of you on the left-hand side as a breakdown of our income. You can see there quite significantly income from integrated care boards, the old clinical commissioning groups, primary care trusts. However long you've been around the NHS, they're different names in effect, but similar source in terms of the funds, and NHS England in respect of some of our tertiary and specialist income and non-PBR income. On the right, in terms of our expenditure, much as you'd expect, significantly weighted towards staffing costs at 398 million, followed by supplies and services, both clinical and general. And just to pull out a few of the significant costs that underpin our service delivery in terms of premises costs, 21 million, the depreciation or the write-off of the value of the estate over the life of the estate, and the concession charges around our PFI, our private finance initiative. You see some quite significant chunks of money there. Just looking at the screen there in the bottom left-hand corner, we invested just over 50 million into the Trust Capital Resources, a huge capital programme that we've never seen before in Worcestershire in recent years. So 37.7 million of that was driven by centrally funded initiatives, particularly targeted at additional theatre capacity at the Alex coming on stream in this financial year, and community and diagnostic hubs together with frontline digitisation. We also generated funds of our own internally, 13.2 million, much of which pointed towards backlog maintenance and equipment replacement programme. So just going back to the top in terms of our criteria, so we did achieve our in-year I&E control total. That's the plan that we'd set down as a board and that we agreed and signed off with our ICB and NHS England. We haven't achieved break-even, taking 1 year with another, which is the duty over a 5-year period to break even, taking 1 year with another. We do have an accumulated deficit built up. We are working on a 5-year financial strategy, but that's not something that we have achieved this financial year. We did remain within the capital allocation, so we have achieved our capital resource limit, and indeed the associated cash levels that underpin that. We have remained within our external financing limits. So all in all, a positive year in respect of our financial performance. Next slide, please, Glenn. In terms of our external auditor's opinion on the 22-23 financial statements, pleased to report that we have an unqualified opinion. So the accounts give a true and fair view of the trust position on the income and expenditure for the year, and have been properly prepared in accordance with the international accounting standards and the group accounting manual of the Department of Health. In terms of the value for money opinion, you'll see there that we have an improving position. We are still somewhat challenged. You can see 21-22 auditors' judgment against 22-23. The arrows on the right reflect a positive direction of travel for each of those areas. The criteria to the left are where the auditors in their 22-23 risk assessment from their audit plan identified they had some concerns that they provided recommendations to us on. So significant risk in relation to financial resilience had been identified at the planning stage. Pleased to report that the auditors have reflected the hard work that members of the team have put in place. They've reported an improved financial sustainability arrangements. However, they do still have some concern about that being a sustainable position going forward. And as I've just mentioned, we are working on a 5-year financial strategy to bring forward to the board and in the autumn. In respect of governance, there were no risks of significant weaknesses that had been identified. And through the audit in 22-23, the auditors have come back with some recommendations that we've taken on board, but no areas of significant weakness, again reflecting a positive direction of travel from the audit. And the final section, improving economy, efficiency and effectiveness in the use of resources. The significant risks that the auditors identified at the planning stage were in respect of the longer term planning to manage the costs of the trust estate, quality and use of data, and sustainable workforce planning and costs. And again, you can see there from the audit opinion in the middle there, progress has been made against all of the areas of significant weakness identified in the 2021 audit. They have removed significant weakness in respect of quality and use of data, and they have returned 2 key improvement recommendations, again around our planning around the estate and our sustainable workforce strategy, but again reflecting a positive direction of travel on the work that we had undertaken during the year. Next slide, please, Glenn. And just a brief look forward. I know that Glenn's going to cover the wider look forward, but this is from a financial perspective. So 23-24 is going to be another challenging year against a backdrop of continuing industrial action, particularly. So we've set a break-even plan for the year, and that is with the support of 42 million of non-recurrent funding from our Integrated Care Board. Our productivity and efficiency programme for the year is the largest that we've seen for some time, 28 million, representing 4.2% of our turnover. And key drivers of that programme are around reducing our reliance on temporary staffing through improved recruitment strategy and targeting agency reductions, improvement in outpatient productivity and efficiency, reduction in reliance on excess capacity linked to improvements in flow, improved efficiency across the estate and back office services, and driving better value for patients through the purchase of products and services. Our plans also include an additional 20 million of income associated with increased levels of planned activity. And the 2 new theatres coming online at the Alex, together with our theatres improvement programme, underpin some of that, some of those plans going forward. We've got a large capital programme again to deliver in 23-24 over 30 million, and we will complete the new urgent emergency care and the theatres facility at the Alex. And as previously mentioned, keen to get a 5-year financial strategy into the board as soon as possible during the autumn. Over to you, Chair. Thank you.
Thank you very much, Neil. Lots of challenges for the year ahead, which we'll go into a second with Glenn. But in terms of the annual accounts, I resolve that the annual accounts be noted. If you're not happy to note them, would you please raise a digital hand? Okay, the annual accounts therefore noted. So Glenn, as you look forward to the year ahead, lots of challenges, not least operational challenges with the various different strikes that are going on. How are you seeing things?
Thank you, Russell. Yeah, it's not an easy period for the NHS, but we are very much in recovery mode as an NHS, but also as an organisation. As Neil just set out there, we have a challenging financial plan for the year that requires us to deliver efficiency savings of around 28 million, but we are going to do that through a focus on productivity, a focus on employing staff directly, reducing agency spend, a focus on making sure urgent care works effectively, and that we electively recover our activities. So the good thing about the financial model for the NHS this year is for all of that elective activity we want to do to make sure our patients are treated as quickly as possible receives a separate payment. So a focus on that elective recovery through firstly the additional 2 theatres that will soon be opening at the Alex, but then also through making sure that those theatres are used productively, but also making sure that our urgent and emergency care system works effectively so that we protect our elective beds so that we can treat patients off the waiting list, but also that our urgent emergency care patients are treated in the right part of the hospital as quickly as possible. So some really important milestones there. And alongside all of that, our cancer recovery, there's 2 main performance targets that the NHS is now starting to focus on: the 28-day fast diagnostic standard and the 62-day referral to treatment standard. We will be ensuring that we continue our improvement trajectory on those 2 measures. From an elective recovery perspective, the milestone for the NHS is to have no patients waiting more than 65 weeks for surgery at the end of this year. And that's a maximum, I would reiterate. We will aim to deliver that, but also have lots of specialties and lots of patients who are waiting far less than that. So I've mentioned the opening of the 2 theatres. The Community Diagnostic Centre Phase 2 at Kidderminster will bring 2 further endoscopy suites on top of the capacity I outlined earlier, which will help us to improve our diagnostic performance. But then importantly for us, the partnership working associated with not only being part of the group, but also being the lead provider in the place in which we operate, so in Worcestershire. And working with colleagues at Wye Valley who are in the group to ensure that we work effectively as an integrated care system, as well as our other partners in the integrated care system. So the foundation group provides a real opportunity for us to continue to be the sovereign organisation that we are, to continue to live to our values and deliver our own strategy, but then to do that in collaboration with 3 other organisations that are very similar to us, facing similar challenges, and sharing our solutions to those challenges across the group. There's also some further developments over the coming year on clinical service networks. One that I'd particularly mention would be a pathology network across Coventry and Warwickshire, Hereford and Worcester, which through the use of digital technology will ensure that we have a more robust, sustainable and efficient pathology service to support all of the organisations across that big geographic patch. And then in addition to the innovation that I've mentioned already, there's some further implementation of our electronic patient record. So later on this year, we'll implement that into our emergency department. And then next summer, we'll be implementing an electronic prescribing system to support safety and effectiveness in that area too. So we'll not be resting on our laurels. We this morning talked through a 10-point plan that will address some of the challenges that we face as an organisation, create a bit of clarity and a drive to ensure that we continue the improvements that we've already described tonight. Thank you, Chairman.
Thank you, Glenn. And for members of the public who might be interested, Glenn's reference to the 10-point plan will be put into the public domain at the next board meeting in October. So we've had a few questions come through from members of the public, members of staff and partners, which touch on some common themes. So I thought I would just read those out. The first is, what we see as the main advantages and opportunities of Worcester Acute joining the foundation group, and whether we think there are any risks or disadvantages. Glenn, would you like to answer this?
Well, I come at this as the chief executive of all the trusts in the group, and I'm very proud of every single member of the group, and they each have some great services and great teams, and therefore I see nothing but positives coming out of being a member of the group. As I just said, we will be protecting the autonomy of the organisation. We remain a separate trust, but the group brings with it that relationship at all sorts of levels. So for all the exec directors, having colleagues who are facing similar challenges, for our clinical services being able to share solutions, and already we've been sharing things between members of the group that will help us to improve our performance, and also that will help to improve theirs. So it's there are only positives coming out of it.
Thank you, Glenn. And the second question, you slightly touched on, but it would also be good to get Jules's perspective on it. We've been asked what extra support might be available for fragile or challenged clinical services through the group structural arrangements. Do you want to start off on this, Glenn?
Yeah, perhaps if I start, Jules, you may want to add anything to this. I mean, there's a particular relationship between Worcester Acute and Wye Valley in Hereford, and there's already been collaboration over the past 2 or 3 years to address what we call the fragile service challenges that exist in both organisations. Good examples of that at the moment are our Wye Valley colleagues helping to address our challenges within our dermatology service by reaching out and delivering some services locally for our residents. But then to reciprocate for that, we will be assisting Wye Valley in Max Fax surgery, because we have a particular ability to help their fragile service. We've also been collaborating on the design of stroke services across the system. And I could add many more. I think the pathology example is another one of being part of a bigger arrangement to ensure we've got sustainable services that deliver locally to our patients. The caveat of all of that for me would be collaborating with others, particularly with group partners, to make sure that we deliver those services locally, because the more local the services are, the better the access for our patients, the better the outcome for our patients. Jules, did you want to add anything to that?
No, sir. Those well-established links kind of with Hereford, with Wye Valley, are there to be kind of optimised by this kind of group arrangement. We've also got an opportunity to work in the other direction across into Swift, which we're already doing with our frailty teams, for example, which has been a massive opportunity, which has been grabbed with enthusiasm, I think, by both sides, actually, that to move that agenda forward. So it can only be viewed as a positive.
No, thank you, Jules. Thank you, Glenn. And then the third area of questions were really about how we might be able to put the patient voice at the heart of board discussions, and our commitment to making sure that we hear from members of marginalised communities, both among our staff and the communities we care for. Sarah?
Thank you. Thanks, Russell. So we are currently reviewing our board patient story process, and we've had that conversation today to ensure that it does capture a cross-section of our patient and family experiences from all of our communities. The other point which I've already raised is that we do want to develop a patient voice and involvement strategy for the trust, and we're currently reaching out to our external partners to support the development of that. It's really important that patients and families are involved in every aspect of their care, and we do want to know what it feels like when you visit our services, so that we can learn and use those experiences to make things better. We know that we can't solve the major challenges that we face without using and involving our patient and families and the general public. So we do want to have a strategy which provides the vehicle to ensure that we do include people in the design and the delivery, and also the assessment of the care and how we're doing. But we do recognise within the trust that there will need to be a change of mindset that enables patient voices to be heard every day. But we are absolutely at the start of that journey and fully committed as a board to do that. I
think the other point I'd add to that, Sarah, is, I'm sure I speak on behalf of all of the board, but Glenn and I in particular as the newbies, we're absolutely committed to creating an open environment where people feel they can speak up about their concerns and anxieties, and know that those concerns and anxieties will be heard appropriately and treated confidentially when they need to be. Whether one just has to have a look at the news flow at the moment, whether it's about the evil of let be or some of the concerns about misogyny in the NHS, we do want to create an environment which is very open to hearing and learning. We know we're not perfect. We know we need to improve to the betterment of all of our citizens, and we've got a programme of work to make that happen. I think the other point which is worth emphasising is we are one of the largest employers in Worcestershire, and our colleagues all have families in Worcestershire, almost always have families in Worcestershire who use our services. So everyone is committed to getting the performance of Worcester Acutes to a better level. We've got a few extra minutes. If any members of the public want to raise a digital hand or a physical hand to ask any other questions, you're very welcome at this point. Simon?
Yeah, thank you. Simon Adams from Health Watch Worcestershire. In terms of patient engagement, it's obviously more than the acute trust, particularly with virtual wards and what have you. And I'd like to hear something about how you're going to join that up across the system. Because frankly, patients don't know sometimes whether they're in your care, the care of the Health and Care Trust, the care of the GP, or in the care of nobody, to be honest with you. I think we need to take, and we will be responding to your invitation, Sarah, to meet with you. But that will be part of our thrust, was how do you as NHS in Worcestershire join this up? Yeah, right? And then the second point I'd like to say, and this relates back to the...
Can we do it bit by bit, Simon? Because I'm at an age where if I get multiple questions, I get confused. I think on the first point, the patient story we heard as a board this morning was a great example of where the NHS and social care, so all parts of the health and care system, weren't working correctly together. And that, I think, was what Sarah was alluding to. So we need to find a better way of understanding the complexity of some of the patient experiences that we refer to. But Jules, your hand went up with respect to Simon's points. Jules?
Thank you. Yes, Simon, I'm hoping, well, if you're not aware now, you will be soon, about our new PISA framework, Patient Safety Incident Response Framework, which involves patient safety partners, which will be kind of recruiting or getting people involved in those. And one of the keys to those new patient safety investigations, they'll involve our patients and relatives as part of that, as our patient safety partners. But B, we're looking at working across the system, so at ICB level, so across the whole system with system partners to look at incidents when they've occurred, so that we can do exactly as you've said, try and link up as the patient moves through our different organisations. As you rightly say, the patient, well, it shouldn't matter to the patient who's looking after them. We just need to make sure all of that links up. So hopefully that'll be a step in the right direction for that as well. So we'll be coming to yourselves for input into that as well, I should think.
Yeah, with respect to Sarah and Richard, if I can come back to you if necessary, but I want to get all the questions out on the table. Simon?
Well, my other question was about being part of the group and the fact that patients very often are telling the same or different organisations the same points, and how you can actually leverage the benefit of the feedback that you're getting across the group about services, and make sure that learning is transferred across the group.
Yeah, no, absolutely. My background is retailing. I spent 25 years in retailing. And retailing is all about identifying and sharing best practice. A Tesco is a Tesco is a Tesco. It might be a large one, a middle-sized one, or a small one, but basically the operating procedures are the same. One of the things I've always found remarkable was that the NHS didn't have that conformity and uniformity. It has different core operating systems, different EPRs, different processes and procedures across different trusts. So when through invitation, Glenn and I were asked to get involved in Wye Valley, one of the things that became very quickly clear to us was even though Wye Valley at that time was the largest percentage financial deficit trust in the country, it was doing some things remarkably well. And so we created a process of sharing that innovation and best practice between Wye Valley and Swift. When George Elliott joined us, we extended that. And absolutely with Worcester Acute, it will be about getting our teams to work collegiately together to learn from one another, but recognise that generally in life, there's one best way of doing things, not four best ways of doing things. And then we identify the best way of doing it, and then we make sure we get that conformity. Glenn, is there anything you'd like to add to that?
No, I think you said it really well, Chairman. I think that the opportunity for particularly chief nursing officers to work together on the quality agenda and chief medical officers already started to do some work on ward accreditation. We look at the inpatient surveys, the staff surveys, and where we can find best practice. There's a real opportunity in the group to get closer to that, to understand why it's working in a particular part of the group, and then share it and take it across all four organisations. So this will hit both quality, productivity, and patient access benefits.
Thank you, Glenn. And any other questions from members of the public or friends who are with us? Okay, I will draw the meeting to a close then, and just reiterate my thanks to all of our frontline teams who day in, day out do their best for the citizens who we serve. I'd like to thank the board and non-executive colleagues in particular for their diligence in trying to support the executive in getting to the performance levels we want. I want to thank all of the volunteers who make such an enormous contribution to making sure we do hear the patient voice, as we've just been discussing, but also creating a really loving and kind atmosphere within the trust in all the different parts of it. So thank you to all our volunteers, and thank you to our partners in the system. We will endeavour to work and be even better partners in the year ahead than we've been already. We are on a journey. It's not going to get sorted overnight, but hopefully by the time we get to next year's AGM, we will see some very strong green shoots of improved performance, which I know is what our citizens and our partners want. The date of next year's meeting will be announced in due course, but in the meantime, I wish you all well, take care, and hope to see you all soon. Thank you very much. Bye-bye.
Thank you.